These are our objectives, so hopefully you're going to be defining the syndrome. You're going to be describing the evaluation process, listing all of the available treatment options, and then describing management for the clinically complicated patient, what I call the special circumstances. Unfortunately, there's not too many special circumstances. So it's important to understand, first of all, I want to touch my stuff here. This is a quality of life issue for women. So thankfully, it's not a dangerous problem, but it is incredibly quality of life impacting, meaning treatment, especially for women who are experiencing bother, can be incredibly important. It's not only helping with the day-to-day symptoms, but research has shown that women who don't receive treatment for this problem do have significantly negatively impacting issues with increased anxiety, depression, and low self-esteem. So it's definitely, certainly an issue that is potentially much more important than what we might think as just postmenopausal vaginal dryness, okay? It's had a lot of terms over the years, been described as vulvovaginal atrophy, atrophic vaginitis, vaginal atrophy, urogenital atrophy, so a lot of different names over the years to describe what we now call the syndrome, genitourinary syndrome of menopause. So how did we get to GSM? GSM essentially grew out of, first of all, a survey that was conducted back in 2013 of postmenopausal women from 6 different countries. And what the researchers wanted to know was what were women's views, what were women's attitudes, how did they feel about the problem, how did they feel about the treatment. And what they found was that most women were very uncomfortable with using the term vagina. They weren't comfortable bringing up this issue with their healthcare provider, and they didn't really understand the terminology. As I mentioned, it's been called atrophic vaginitis, and we all know itis, sounds like something that's a disease process or some sort of inflammatory process. And so there was really a lack of understanding. What the researchers found in querying these women, that there was a huge lack of understanding of what the problem was in the first place. So in 2013, they did this survey, and then in the end of 2013, early 2014, ISWISH, the International Society for the Study of Women's Sexual Health, and NAMS, the North American Menopause Society, convened a committee to look at 3 goals, 3 objectives that they laid out for themselves to answer. And those objectives were, 1, to thoroughly review the literature on genitourinary atrophy, to create a term that would encompass all of the symptoms, the research, the education, and then to develop a system to disseminate that information. The overarching goal, of course, was for there to be a more concise, more appropriate, if you will, definition, description for this condition. And so out of that committee came the term genitourinary syndrome of menopause. So since 2014-ish, around that time, that is the new nomenclature, the new terminology for this condition. So again, what is GSM specifically? It's an assortment of symptoms that women experience transitioning from the peri-menopause into the post-menopause process of life. And multiple systems are affected. So it's a multi-system syndrome, including the lower urinary tract system of the urethra and bladder, the vagina, the vulva, the clitoris, and the perineum. So it's more than one system being essentially affected, if you will. And it also includes transitions from a premenopausal state to a to a postmenopausal state, including all of those anatomic and physiologic changes that occur going from an estrogenic state, if you will, to a hypoestrogenic state, including also the onset or the hastening of the collagen loss, deprivation, reduced vascular supply, and thus ultimately a thinning of that vaginal epithelium. So the issue is with GSM and the term is to try to take away the negative impact, the negative feeling or thought around the syndrome, and help not only women, but certainly us as healthcare providers have a little bit more ability and openness to be able to bring up the topic. And we'll talk a little bit more about that here in just a second as to why it's a difficult issue to discuss. So symptoms can include not just vaginal dryness and discomfort with intercourse, but it can also include urgency and frequency of urination, urinary incontinence with that urge, so urge, urinary incontinence, and then recurrent urinary tract infections. So recurrent urinary tract infections is not the focus for this talk, but certainly that can be one of the outcomes of this syndrome. Symptoms don't dissipate over time. So a lot of women say, yeah, I had hot flashes, couple of years they got better. Well, with GSM, symptoms don't improve with time. They actually worsen with time. And what research has shown is that when we looked at women essentially 1 year post-menopause, about 64, almost 65% of women expressed symptoms. You move forward in time and look at them, I don't know why they picked 6 years post-menopause, but they looked at women 6 years post-menopause and saw that that number had increased to almost 85% of women experiencing symptoms. And so again, average age of menopause is anywhere from 50 to 55, somewhere in that window. And so you're looking at 6 years post-menopause, those women are around 60. Not that old, and certainly in this day and age, women who are 60 into their early 60s are still very active, leading very active lifestyles. So this can be a very, very negatively impacting problem. So symptoms, they looked at symptoms ranked by bother, and what they saw was that the number one symptom that women did complain of when asked was dyspareunia and vaginal dryness and itching. And so that kind of makes sense to me, because while they might be having urinary symptoms, the urinary symptoms don't necessarily, might not necessarily affect relationships. Dyspareunia, vaginal dryness can absolutely impact negatively those very intimate, significant other relationships that they have. And so that doesn't seem very surprising to me. If untreated, again, it is absolutely going to continue to negatively impact that quality of life. And as I mentioned earlier, with symptoms of depression, low anxiety, and low self-esteem. And so this has been very well documented. So it is actually a very important condition for us to treat. When we're looking at prevalence, it's all over the map, unfortunately. You'll see literature that cites the prevalence of this problem as low as 10%. I looked at some other studies, 60-something% to as much as 80, 90%. So it's all over the map, unfortunately. The EVES study noted the prevalence as much as 90%. So why the underdiagnosis? Why the low prevalence? Why the prevalence that's just skewed all over? And a lot of it really is multifactorial. In 2016, Parma et al. Looked at both the objective and subjective findings of the problem, and what they found was that 79% of women actually had clinical signs,